Okay, good morning, everyone, and thank you, Perry and Scott MacDonald and Kate Salters for coming on to this panel. It's not meant to be a panel that's going to be out there talking to the public as much as wanting to try and shed some light on some of the complexities of the whole issue of the overdose deaths that we've been seeing. It's not simple. There is no one silver bullet. There is no one answer. There are many complexities that occur that make this a very, very difficult issue. But at the same time, it is something that we need to tackle. And the three of you here are probably the people that know the most about it and are able to shed some light. Many people who have substance use disorders have comorbidities. There may be mental illness, there may be hepatitis C, A, B, there may be HIV, there may be all kinds of other reasons why it's not one simple thing about substance use disorder. The second component is that we know that the fact that many of the people who have substance use disorders are homeless doesn't just mean that you can find a home and put them in it. We know the complexities of many of these people don't trust organized anything, including organized medicine, organized clinics, government, etc., and don't necessarily want to be housed in a traditional way. And there may be issues of how we house them in an appropriate manner that fits their needs. And so I remember being there, and as I said earlier on, Perry, you and I remember being there at the beginning of all this in the 1990s when Philip Owen was mayor, and we were faced with overdose deaths at that time. We thought 400 overdose deaths a year was extraordinarily high. Today, we know that is just a drop in the bucket, but in those days, it was pretty simple. In many ways, it was just overdose and HIV, AIDS, and hepatitis C overwhelming everything. And we started at that time, the three levels of government came together, set up the Vancouver Agreement, where the federal, provincial, and municipal government worked together with many other groups, and universities and NGOs, etc., to try and find a response to this. As a result, we talked about harm reduction, and we also set up the first North American safe consumption site. But people will say, well, if you did this in the 1990s, why haven't we fixed this problem? What is continuing to go on? And without trying to be partisan, I would say we had 10 years of governments that blocked, a federal government that blocked everything to do with harm reduction. It was a dirty two words that nobody liked to hear. And they also spent a lot of time in courts fighting the safe consumption site, which we know actually saved lives and completely removed the overdose deaths of the time, helping us to create on-site, which helped people to get to detox and treatment when they needed it. It's a totally different story now. We have contaminated source that is contaminated with fentanyl, benzos, carfentanil, etc. And so life has become far more difficult, and we're seeing more people now die from overdose than are dying from COVID. Many, many more. And it's not just a British Columbia problem, it is now a national problem. And we need to look at what we can do, all levels of government working together to try and A, stop overdose deaths, B, prevent them where possible, get people the care that they need immediately so they don't have to die of overdose deaths. The other thing we know is that overdose deaths are not just limited to those people that everyone likes to point their fingers at as vulnerable in society. We know that families with kids are involved in substance use disorders. So it's not, again, as simple as it sounds. And again, the idea of a silver bullet is not something that we can talk about, but we can do things. And I wanted to perhaps talk to you who are at the core of this. Perry Kendall, again, Perry has been the Chief Public Health Officer in British Columbia for a long time, and when he retired, as we know, Dr. Bonnie Henry took over. But Perry was there at the very beginning and was very involved in looking at these issues of the first supervised injection site in all of North America in the 1990s, and continuing on to deal with this as a primary problem for him, as well as to deal with Indigenous issues, which, again, he was at the cutting edge at that particular point in time. Dr. Scott MacDonald, you are, in fact, the person who is responsible for the Crosstown Clinic in the downtown east side, where you are giving then injectable drugs to many people who have not responded to methadone and the usual forms of treatment. And we know that there are some problems. You and I talked about them, about getting hold of injectables. Dr. Salter, I can't say that I know you because you're so young. And us old fogies here sort of went back, way back in time. But I mean, I do know that you work closely with a very good friend of mine, Dr. Julio Montana, who has been very involved with this from the beginning, who was part of this, the UBC study on the safe injection sites, safe consumption sites, and Naomi and Salome and all of those things with many others there. And so he cannot come on because I don't know, he's somewhere in the wilds of British Columbia, unable to achieve Wi-Fi. And I know that you're working closely with him on HIV and other comorbidities and on this particular issue. So welcome, all three of you. And so what I'm going to do is I'm going to start with Perry. Perry, you mean you've been there from the beginning of this all starting here in British Columbia, in the downtown east side. And perhaps you can just fill us in what you have seen change from that time, over the course of time, to now, where we are dealing with the massive overdose deaths, not only in British Columbia, but across the country. And what are the things you think that we need to pay attention to first and foremost? And what are the barriers that you see stopping us from, you know, waving a magic wand and making it all disappear? So perhaps you can tell us, Perry. Go ahead.
A simple question, of course. Thank you, Hedy.
You can answer it, Perry. I know you can.
Okay, thank you. So I would like to acknowledge all the help that we're getting from Health Canada on this file, and particularly Eric Costin and the work that he's been doing. I think fundamentally what underlies all this, if we really want to dig into it philosophically, is a societal relationship with psychoactive substances, which, depending on which substance you look at, is either completely irrational, somewhat beneficial over time, getting worse, or harmful. And I think that what we have failed to recognize is that we do have an ongoing relationship with psychoactive substances. Some of them we have decided to control through sort of making them illegal and trying to prohibit usage and punishing usage. And we have done that without recognizing that trying to cut off a supply without actually managing demand or vulnerabilities to it actually makes the situation worse. And I think what we've seen over the last 20, 25 years in British Columbia anyway, in regards to illicit substances, non-prescribed stimulants or opioids or whatever it is that we've tried to cut back on supply. We have done very little to manage the demand, which in fact has increased over the decades as sort of social inequalities have increased. We've seen recently deaths of despair since the late 2000s, particularly in the United States. And we've been very unsuccessful in meeting a demand for substances which we have deemed to be illegal, and we have tried to banish them to actually increase the safety. We banned them because they're dangerous. Banning them has actually led to the inevitable law of increased toxicity and increased potency. It's a sort of economic fact that if you're trying to import something to meet a demand and create a profit and it's illegal, it's much easier to import something which is very, very potent in very, very small amounts than it is to import the raw substances. And invariably that increases the potency, that increases the toxicity and the danger. So we've had a completely paradoxical response in regard to opioids in trying to keep opium out and heroin out. We have ended up with carfentanil and fentanyl, which can be produced in the laboratory, which can be accessed through the dark web, which can be delivered to your doorstep in a package of, half an ounce, which will contain thousands of potentially toxic doses. So it's an impossibility to try to stop it. What has happened with COVID is that there has been some success, I think, in the importation of substances from mainland China. So we now have our own producers on the continent of North America. And we've seen deaths from heroin decrease, but we've seen that has been replaced by deaths from fentanyl, carfentanil, and a range of other toxic substances on the market. And we've actually failed to this point in time to address, I think, some of the unhelpful policy legal frameworks. We've made some little dents in changes to, say, Section 54 of the Controlled Drugs and Substances Act to allow harm reduction measures to come in place. BC is currently moving, I think, ahead of anybody else in North America to increase access to a safer supply. That still has to be a prescription supply. But just yesterday, there was an announcement of a policy shift between Public Health, the Ministry of Health, and the Ministry of Mental Health and Addictions to increase access to a range of pharmaceutical alternatives to the toxic street drug supply, including everything from stimulants, powdered cocaine, to even looking at powdered fentanyl. The only thing that seems to be missing is diacetyl morphine from that list. And all this is really acutely aimed at trying to prevent overdose. I think we're not very good at preventing the vulnerabilities that individuals gather over a lifespan, either antenatally or postpartum or in their infancy, which makes people vulnerable. We're not very good at mediating those at the present time. We don't have a very good healthcare system, primary healthcare system, that's not very good at recognizing addictions. And problematic substance use. We, at the political level, have taken, I think, good steps around dealing with what was a sort of epidemic intoxication of dependency on nicotine. We've moved sensibly in that area. We've gone completely in the opposite direction with alcohol and the harms of alcohol over the last 30 years. And if you look at it from 30,000 feet, more people actually die of alcohol through cancers, cytotoxicity, accidents, etc., than are actually dying of opioids or mixed drug overdoses. It's just that they do it over the course of a lifetime, as opposed to very acutely, basically in their 20s, 30s, 40s, or 50s. So I don't think there's any easy answers to that. I think that trying to manage the discrimination and criminalization of people who've become dependent on substances, or who are even using these substances intermittently because they're seeking some kind of relief from the daily grind. So expanding access to a safer supply is one critical piece. I think trying to destigmatize and decriminalize and recognize this as a health problem is another piece. And trying to replace the criminal black market with a regulated market is something that we should be aiming at. At the same time, we should be looking at prevention, and at the same time, we should be looking at secondary prevention, tertiary prevention, treatment, maintenance, and recovery.
Thank you so much, Perry. I think you've just put that in a nutshell for all of us. I know that the federal government has been helping with British Columbia, which is ground zero and which is actually at the cutting edge of what is going on. That the federal government has been helping with funding, the prevention and the availability of naloxone, et cetera. Those are all part of it. But the federal government has been trying to work on a safe supply. And I know that that has moved forward to some extent, and the province of British Columbia has been looking at safe supply, as we well know, prescribed by primary care physicians and by nurse practitioners, and now they've expanded it just a little bit more. And I know that the Minister of Health federally, Patty Hedy, is going to be making an announcement on Monday with regard to this kind of thing. I know that all of that has been in the works, but at the same time, there are those people for whom a pill is not the answer. I mean, we know for some people taking an opioid in pill form is fine, taking one of the substances that they need in a pill form is fine, but we know that there is a need for people who are the ones who are basically the people who are highest risk of street drugs, who are using intravenous, who are using different modes of access to the drug within their body. You're having trouble because we don't have good access to the intravenous drugs. And Scott, you and I were talking about that not too long ago. Can you elaborate a little bit on that?
Well, I totally agree with you. There is a small but predictable population that will only respond, only be retained in care with an injectable option. And we've been providing injectable treatments at Crosstown as a program since 2014. Initially, it was extremely onerous to do some of the importation and supply, but Health Canada and your government have made procuring so much easier. So thank you, and thank you, Health Canada, for that support. Opioid use disorder is a manageable medical problem. It's a mental health diagnosis. And just like hypertension or diabetes, it can be managed. And just like high blood pressure, some people are going to require second or third level treatments. And for opioid use disorder, that may be an injectable option. We ran Naomi, which showed that prescription
Now,
heroin.
just for the sake of the listener, what is Naomi? Can you tell
Naomi
us?
is the first prescription heroin study in North America, the North American Opioid Medication Initiative. Ran here in Vancouver and Montreal from 2005 until 2008, published in New England Journal of Medicine, showed that prescription heroin is both clinically superior, but also more cost-effective than methadone. Should be available. Unfortunately, we weren't able to benefit in Canada from that. I joke facetiously something that only Denmark benefited from Naomi. They looked at the results of that study and said, well, we don't need to do any more studies. We're going to incorporate prescription heroin into our healthcare system. That initial rollout was so successful in 2010, it's been subsequently expanded and is now integrated into their healthcare system. And they did not expand for a illicit drug overdose deaths. They expanded because it was simply a solution to a public disorder problem. At Crosstown, we see folks who on average have been injecting opioids for 15 years, have on average had 11 attempts at treatment. We knew from our Salome recruitment that we needed at least 500 treatment slots in Vancouver alone back in 2015. That was a year before the public health emergency was declared. Currently, only about 200 or so people have access to injectable treatments in all of British Columbia. That we're not meeting the need. But
why not?
Well, if we can show that this is more clinically effective than oral treatment and more cost effective, it should be expanded. On top of that, this will reduce mortality and also reduce crime, both property crime and violent crime. The obstacle is just willingness to pay and lack of availability. We need a domestic supply of diacetylmorphine, and we need a commitment from the provinces and perhaps the federal government for at least 1,000 or 2,000 treatment slots. That would make it viable for a pharmaceutical company to produce diacetylmorphine. Now,
yeah.
this is for a small but significant number of folks. And unless it's available, they are not going to be attracted and retained into care. And there's a few other reasons why it might be a challenge. There's a overlap between the criminal justice system and opioid use and people who are dying from illicit drug overdoses. The coroners in their death review panel noted that almost 2/3 of the people who have died, the decedents, from when the public health emergency was declared here in British Columbia until 2017, had been in jail in their lifetime. The population of Crosstown, 80% of our patients have been in jail for at least a month with a huge amount of variation. We are managing as a country and as a society a medical problem in a very expensive and inefficient model, which is the criminal justice system.
Thank you, Scott. That is very interesting. We're going to get back to some of the availability, et cetera, of diacetylmorphine. But I just wanted to go to Kate. Kate, you are dealing in many ways with some of the comorbidities, as we like to call them, which means the other things that people are actually experiencing as a medical problem other than just their substance use disorder. So perhaps you might want to tell us why that is important, that we recognize and do something to prevent and or to treat and or to deal with those comorbidities, including mental health issues. So can you just tell us a little bit about that?
Sure, I'm happy to. So it's a pleasure to meet you all. I know this is the first time I'm meeting all of you, so I'll give a very brief background. So I'm not an addiction expert, but I did my MPH and my PhD and have been working for the last 10 years in HIV and reproductive health. And I've been really fortunate in the last couple of years to really step into leading the viral hepatitis program at the BCCFE in the downtown east side. So I work at the 625 Powell Street location. So we are 2 blocks away from Oppenheimer Park. We are based at a low barrier now primary care facility, and we run clinical programs and research programs out of that facility. So while I work in HIV and hepatitis C, we see and we cannot ignore the fact that we are not dealing with one siloed epidemic. We are talking about a syndemic issue, that people living with HIV and hep C, they can live long lives and they just aren't in many settings because of the overdose crisis. And I think why Julio wanted to invite me and give me the opportunity to speak and chat with you all was because some of the more recent research that we've been doing has really highlighted just how simply we can't ignore in the field of infectious disease how much this intersects with mental health and addictions. So we know that people living with HIV are about 15% of people between 2014 and 2017 died of an overdose. And that it's actually the first time in more than 2 decades since the advent of new therapies for HIV, and then more recently for hep C, that we're actually seeing a decline in the life expectancy of people living with HIV and hep C. So to ignore addiction would be a disservice to anybody living with or at risk of HIV and hep C, which is which I think is what I can speak to a little bit more. I come from a background of women's health and reproductive health, like I said, and one of the more recent research pieces that we've been working on has really highlighted how this has disproportionately impacted women living with HIV and hepatitis C. We know that women living with HIV have a higher mortality rate. So about 25% of women since 1996 living with HIV have died, and about 1 in 5 of those women died from an overdose. And in the last 4 years, that has bumped up to actually 1 in 4. So a quarter of women living with HIV die from an overdose in the last 4 years, which there's even worse outcomes if you're living with hepatitis C. There's a even 40% lower probability of survival. So we know that women, we know that urban populations, we know that Indigenous folks, we know that this intersects with a lot of different factors that precipitate higher risk of overdose. So I think we've gone beyond the time of just looking at one infectious disease and coming up with one solution. This just so clearly intersects with mental health and addiction. And we looked more recently at an audit of all people living with HIV who have died of an overdose in the province. And about a third of those deaths were women, and about 50% of the people that we looked at that died of an overdose living with HIV had never actually been prescribed OAT or other options. So another flag for the need, and not just in Vancouver, but across the province, to support folks that are suffering from substance use.
Kate, I just wanted to say, you mentioned a lot about how HIV and substance use disorders intersect around women. I know that because, of course, I'm a physician and I have been following this and getting all the data. But, you know, a lot of people don't get it. They want to know, how does a woman get HIV? Because there is this whole myth that it's only a gay man's disease, or it's only an intravenous drug user disease. But the point is that we know that women are, and women do need support systems because of they have HIV and they have all these conflicting other pieces of health issues that they have to deal with. So I'm glad you did mention the women, because I think that there is a bit of a myth around this. And so what I wanted to go back into here now was that what you were telling everyone, and what I'm hearing from you, is this is not a silo. This is not a one thing that we can do and one thing that's going on. Cuts across a whole lot of other things. And so therefore, the ability to deal with this particular issue of substance use disorders, of overdose deaths, of other morbidities, of other deaths because of concomitant disease factors, and that it is a health issue at the end of the day. We're talking about health issue here. We're not talking, as Scott pointed out, about criminal justice systems and criminality. The criminals are the people who exploit the vulnerabilities of this population group by selling them drugs on the street and by giving them tainted drugs, et cetera, et cetera. So that, you know, we have to deal with it first and foremost as a health issue, and look at all the health components of it before we can talk at all about dealing with this issue from a one size fits all point of view. Scott, earlier on you were talking, and I think maybe I'm going to ask you and of course Perry to weigh in on this. This lack of availability globally of diacetylmorphine. What are we going to do about that? I know that Switzerland has, because Switzerland started all of this looking at the issues of diacetylmorphine and having public clinics providing safe supply. But we know that in Scandinavia, they're also doing this. Where are they getting their drugs? And what can we in Canada do, as you say, to provide the injectables? I think a couple of big pharma companies in Canada make them, but for me, I think it is really extraordinarily expensive, because they make it for hospital use and for OR use and for acute care use for medical problems. But you know, what is it we can talk about? How we get to this of getting that injectable availability within Canada, within British Columbia, and of course Canada at large. What are some of the things that we can do? And I'll go to you first, Perry.
Okay, so I think the issue is currently that there is no domestic supplier, licensed supplier for diacetylmorphine in Canada. Ever since Naomi started up, and it took 2 years to overcome the regulatory hurdles, we've been importing diacetylmorphine from Switzerland. We also, there is a regulatory burden that we can only import so much. We have to get permission from, I think it's one of the UNDP drug oversight programs. Canada is limited to 48 kilograms, which would be enough for about 250 patients. We currently use about 28 kilograms, I think, just for the Crosstown and the small clinic in Fraser. It's also important. It's also very costly. The primary active pharmaceutical ingredient, which was $5,000 a kilogram, the company was recently acquired by an American pharmaceutical company, and the cost has gone up 400% to $20,000 a kilogram, and that would be an active pharmaceutical ingredient. We also, the product format as it currently comes in, and I think, Scott, you can correct me if I'm wrong on that, but according to Marty Schechter, it comes in a very large format. It has to be sort of processed under pharmaceutical best practice conditions, which adds to the cost of it. So just on a personal note, Dr. Schechter has, about a year ago, launched a proposal to get a not-for-profit cost recovery domestic supply of diacetylmorphine in Canada, and I am working with him on that. None of the larger pharmaceutical companies in Canada or North America have really been interested in applying for a license for this product, because I don't think they see the market as being large enough to make it worthwhile. And certainly I don't think we'd ever see it under the current political regime or even the past political regime, something that would be available to individuals as a pharmaceutical alternative to methadone or Suboxone in the United States. So we've got a limited market. We've got a high cost product, which is somewhat difficult to get in, has to be changed. It doesn't come in a vial, a single-use vial that could be given to an individual for usage in the day. So I believe, Scott, again, you can correct me, that there was initially with Naomi fairly substantial wastage of the product as well. So that's kind of why we import it. It's expensive. The product isn't the ideal product. And if we had a domestic supplier, and if we were doing it on a not-for-profit basis, I think we could substantially reduce the cost and certainly make it a lot more available. But Scott, you can fill in the gaps on that one.
Do you want to jump in here?
Oh, sure. So firstly, hydromorphone is available now and licensed for analgesia, so for pain. It is available. But as you alluded to, Hedy, we're paying the same price as paid in hospitals for acute care. So it would be nice if a lower price could be negotiated for the opioid use disorder indication. We also have to buy hydromorphone as a solution. If there was a lyophilized powdered preparation, that might get costs down as well. If you look at diacetylmorphine or the prescription heroin, yes, we have to import it from Switzerland because that's the only country that produces for export. Some of the other countries in Europe produce their own supply, but they do not export it. As well, Diamo, the company in Switzerland, is a small company, and really they can't expand any further. With any luck, the Fair Price Pharma Company might be able to produce next year, or another manufacturer. But as Perry alluded to, though, the amount that we would order would need to be reported now so that the amounts could be increased for next year. So work and planning needs to be done just to have increased amounts of diacetylmorphine for the end of 2021. And we expect that thousands of people are going to be dead in the meantime. So there's urgent work that needs to start immediately. And there's regulatory challenges around how it's dispensed. Sort of as an artifact left over from the study, we were producing our drug in a $1 million NAPR compliant negative hood with a whole team of pharmacists. This is expensive. In Switzerland, they've shown that the syringe, the vials, when drawn up by a nurse, that they're stable for 24 hours and up to 2 weeks. So they have none of that. They just stick a dispensing pin in the reconstituted vial of powder with distilled water, and a team of 2 nurses will draw up, make sure it's the right dose, confirm that it's given to the patient as it's prescribed. And that gets costs down significantly. But there will be challenges to work out through provincial regulators, College of Pharmacists in every province, and there's a national organization called NAPRA. But none of that's necessary. If we just had this as the standard of care, a company could show that the vials are stable, microorganisms don't grow beyond a day or up to 2 weeks, and then we have a solution. It's available.
So what is the federal government's role in making this so? And you both are making a case for, which is something that has been, rolling around in my head for quite a while now, years now, is that as we look at drug shortages, just drug shortages, ordinary things like drugs for high blood pressure and drugs for diabetes and drugs for epilepsy, etc. There's a global shortage of drugs because it's not paying the generic companies to make these anymore because they're not making money on it. Is there a case here for suggesting, without making everyone scream, oh my God, socialism, communism, is there a case for Canada doing what it did once with Connaught Labs, doing vaccines? Is there a case for Canada to become, as Perry was suggesting, either from a non-profit point of view, to be making our own pharmaceutical supplies in many instances, especially if we're talking about pharmacare, that's going to be cost effective for us to be able to do. Is there a case for that? Perry?
I strongly believe that there is. I mean, this is, if we were talking about a pattern of care for cancer, and there was a treatment that had been available for a quarter of a century in Europe that was proven to be efficacious and effective and cost saving, I think there'd be an outcry if it had been made available in Canada or North America at some point during that time. And I think that if there was if profit motives stand in the way of it, which they do for many drugs, orphan drugs, I think there is a case to be made for government intervening and stepping in this area, either by sort of subsidizing. I mean, there's still a regulatory pathway to be filled, obviously. Like with any vaccine or any drug, the production has to be appropriate. The product has to be sterile. It has to be safe. It has to be effective. You have to have sort of post-marketing vigilance and surveillance in place. But I do believe there is a case to be made here where the private sector can't move in or won't move in an affordable way. I think you can make a strong case for government intervention.
And that would be a federal government intervention in terms of looking at standardization across the country, et cetera. I think, because you're right, if profit is the motivation in terms of drug companies or large pharma or even generic companies making drugs because it's no longer profitable for them, then somebody has to step in that says, we don't care about profit. We just care about getting this to the people who need it. And that would be, as you suggest, a case where a federal government might step in and say, hey, there is something that we need to look at here. Can we, especially if we're looking at pharmacare, make drugs more readily available for our people without having to go down the road with our hat in our hand and begging global markets to get us drugs when we can't get them for our own people? So I think that is a very interesting thing that just came up. Do you, Kate, do you want to weigh in on this, or do you feel this is something you don't want to weigh in on?
No, I agree with what's been said. I think those two have a lot more wealth of experience with regards to the pharmacare than I would be. I have nothing to add on that point right now. But thank you.
Scott wanted to say something. Yeah.
I have one thing to add. Yes, we need domestic production, but we will also need domestic production of the raw materials. The source for diacetylmorphine and for and many of our opioid analgesics is the opium poppy. And I think most of the world's supply comes from the UK and from India, but it will grow in southern Alberta and it will grow in the Fraser Valley. And we will need to have opium poppies as a domestic agricultural product and source of raw materials. And that's going to be a longer term project than next year, but that work needs to be done as well.
Okay. Do you think there's a role in the interim, because we have an interim here, even if it takes us a year to get up to scratch on producing some with a nonprofit company, like Perry was talking about with Marty Schechter, what are we going to do in the interim? What is the suggestion in the interim? Is there a role that we can play in getting the pharmaceutical companies in Canada who are selling it at the same price they're selling it to hospitals to bring down the cost specifically and only for substance use disorder? Is there a role the federal government can do in negotiating that, or in talking to them about that, or in trying to make that happen?
Well, possibly, and there are national organizations that will negotiate drug prices and for new pharmaceuticals and for new indications. There's a Dr. Ahmed Bayoumi who works in Toronto at St. Michael's Hospital. I know that he's on some of those committees and is interested in doing this work and hearing from provinces or federal government if they were interested in negotiating lower prices. The products for injection, because they need to be sterile, are always going to be more costly than a tablet or a pill, which doesn't need to be sterile. But even at the high price that we're paying now, both of these drugs, both of these treatments are cost effective. But we could get the cost down significantly with domestic production and some of this work being done. And then I am hopeful that provinces and jurisdictions will be willing to pay.
Yeah, and I think you're making a point there that perhaps it's not, it's not available globally. B, we have to make it available, and so we may have to look at a domestic production here. And C, costs are high. So if we looked at non-profit pharmaceutical companies making it, then that might bring down the costs. But at the end of the day, no matter what the costs are, it is cheaper to treat with a safe drug supply than to deal with all of the impacts and all of the side effects and comorbidities of people who have substance use disorders.
Yes, diacetylmorphine and hydromorphone dominate methadone in the population that continues to use illicit opioids despite attempts at the standard oral treatment. And in that case, when a new treatment is both more clinically effective and more cost effective, it should be provided, expanded, and made available.
Okay. Kate, did you want to jump in here on something else that you think needs to be done as we're looking at how we deal with the whole broad comorbidities and the issue of substance use and all of the other problems that you just explained to us earlier on with, HIV and hepatitis C and other infectious diseases? And I just, before you could answer, I wanted to say that I like how Scott alluded to, it is like dealing with diabetes and other chronic diseases. This is not a moral issue at all. This is a chronic problem that needs to be dealt with in the same way we deal with other chronic diseases like high blood pressure and diabetes and possibly things like epilepsy and stuff like that. So anyway, did you have something to add to this in terms of the as we like to say affectionately in medical terminology, comorbidities? It means other things that you get other than the one thing you have right now?
Yeah, I'll highlight that. So Scott's point is so well taken. And I think Perry also mentioned earlier that, I think it further highlights that people are, when we're talking about substance use disorder, we're more interested in preventing overdoses than we are in actually helping people who are ongoing and suffering day to day. Our preoccupation with just preventing the overdose and just preventing the transmission of HIV and Hep C is the overall focus. And I think that paradigm shift and that shift away from people who use drugs are bad towards how can we address the underlying trauma in many cases and the other issues of homelessness and poverty that often are some of the root causes is I think one point that is so well taken. I mean, I think both Scott and Perry spoke really well to the safe supply. The only thing I would highlight, and I maybe speak for a little bit of a more focused experience in the downtown east side and seeing what's happening recently, is having options for folks. Certainly, as Scott and Perry had both mentioned, methadone may work for, we may have options for people, but we're seeing that there's a growing proportion of people that's not working for. So injectables are great. And then you go to Insight and most people are actually coming in for crystal meth and fentanyl use. So having safer supply for stimulants and other medications are going to be increasingly important. So I think that the scope of things, we often just are thinking about things like heroin and fentanyl, but really we're also talking about stimulant use and other things people are bringing in and using that are getting increasingly tainted and are a huge problem for, again, shifting away from not just focused on preventing overdose, but how do we better support people who use drugs? And I think if we are shifting to, we're dealing with it as it is another chronic disease like diabetes, that's the mentality we have to take. So specific
That's important
approaches.
Because everyone focuses on the question of how do we prevent overdose deaths? Now that's important, obviously. But what you're saying is it's not just about preventing overdose deaths, it's about dealing with what the chronic disease consequences are. What about the chronic illnesses and the mental illnesses and all of these other things? And so I always find when people say, well, if we do this, will it fix things? I always think, this is this old whole silver bullet argument. If you do one thing, everything will disappear. And what you are making a case for, it's not only about stopping overdose deaths, it's about looking at the chronic disease problems that result and that are going on with many people with substance use disorders. And then I'm going to segue into one other thing. and I think Perry and Scott may not want to talk about this, but I know they're going to talk about it, and it's what do we do about the problem of people who are mentally ill, who have been filling our streets, the homeless people who cannot be housed in the normal fashion. You know, this all started as, again, Perry and I, long in the tooth, can remember, when we deinstitutionalized everyone, and everybody who had a mental illness was set out there onto the streets with no catchment for them. No trained physicians to take on people who were mentally ill, no problems, no support systems out there for their families, and etc. And so we now see that happening. But everyone thinks that if you find housing for everybody, you're going to resolve this problem. And I just wanted to have a little chat about how do we deal with this other problem that we call homelessness. How do we look at this? Because it's not, again, a simple solution. Did you want to weigh in? Any one of you want to weigh in on that? Well, Perry, I'm going to ask you first, because you're a public health officer, so you should have all these answers at your fingertips, right?
Yeah, right. Well, there's been a lot of really good work done by Julian Summers at Simon Fraser University, looking at the spectrum of concurrent disorders from moderate to severe, and looking at housing first as an option. And housing first is something I think they do better in the United States than we do here. Although
Yes.
the Mental Health Commission did spend a lot of money over several years, actually, you know, housing people with the supports that they actually needed, whether they were social supports, whether they were mental health supports, whether they were substance use or primary care supports. And basically, most of the people who go into a well-designed program of a variety of intensity of supports, from moderate to fairly aggressive outreach supports, actually do quite well. And it, again, is one of those programs that turns out to be cost effective. If you can take out the cost of illness, of hospital care, of jail time, of running through the courts, et cetera, et cetera, et cetera, these programs have a really good return on investment when compared with other standard medical interventions for which we're happy to pay. It just does require a significant investment in one area. It does recoup the costs, reducing the costs in other areas, but we don't have an economic system that actually captures that. So it was proven to work a little bit like the basic minimum income was. It's just not something that's been adopted or invested in to the sufficient level. I mean, Scott or Kate, would you add to that?
Before they add to that, I want to say that I think as we are now hearing that the Prime Minister is coming up with a speech from the throne, and one of the reasons that he's coming up with a new speech from the throne is that COVID-19 unearthed or opened up a whole lot of gaps in our system that we had not been dealing well with in our old system of social infrastructure. And how do we fix that? And this may be one of the pieces that need to be discussed as we're talking about how we look at it from a new perspective of fixing. So I'll have Scott and Kate, and I think we're coming up soon to looking at how we end this forum. But Scott, why don't you go ahead, and then I'll go with Kate.
So at Crosstown, we have social workers. They work very hard to find our patients housing when they need it. 80% of the folks that come into Crosstown had unstable housing or were homeless in the 2 years prior to presenting to us. And we're able to get everybody housed or find shelter. And thanks to the work of our social workers, our patients have a reputation that they can be managed in housing. So if people get care, have access to services, they can be housed and find shelter.
Are you saying then, Scott, that looking at problems that have to do with health should have more than just doctors and nurses involved? Are you suggesting that we have social workers and housing advocates involved in this? Isn't this sort of a remarkable way of looking at a system that people like the United Kingdom has already began to look at the broader group of people that need to be involved in health solutions, that it isn't just about doctors and nurses and healthcare providers. It is about housing and social work and and other components. Are you daring to suggest that, Scott, is a new infrastructure for us to look at?
I am suggesting that simply providing a drug is not sufficient. It is about how that care is provided and patient-centered care, and part of that is comprehensive care. Absolutely.
Thank you. Kate?
Yeah, I couldn't have said it better. So we opened up this low barrier primary care clinic, and every person that comes in has the option to speak with our social worker. And she is far and away the busiest person at our clinic, the most in-demand person at the clinic. And when I talked to one of the clinical program managers at Insight, I asked her recently, what is the biggest thing that you think the system could benefit from outside of safe supply, outside of things like that? And she said the biggest thing that we could do is have hospitals and primary care clinics be able to support high risk patients with a case manager or a counselor. If we have those services available in a low barrier way and we're able to connect people better, things like understanding how trauma is linked to mental health becomes the forefront of the discussion rather than a secondary piece. So I'd further echo what both yourself and Scott said.
I think, I remember in the old days, everyone used to say when the World Health Organization was struggling to find a definition for health, and they said that health was more than just the absence of disease, that it had to do with all of the other things that give an organism, a person, a thing, the ability to survive in its changing environment, and that was what health meant. And I think that it's interesting that as we are now talking about how we look at moving towards a different social infrastructure than the one we had since the Second World War that served us well then but isn't serving us well anymore, and how we segue. One of the things that I think we need to look at is how other countries have done this and done it well, and get the evidence out of those countries and look at best practices to say that, sometimes we don't need to go and do 5 years worth of studies to reinvent the wheel, that we can actually look at how other people achieve the same things and probably look at the outcomes and see if it can happen here in Canada, if it is something that we can parachute into our system. And I think we have an advantage in that we do have, I know the College of Family Practice has been talking a lot about the patient-centered system, where in the old days, it was the patient went from place to place and the center of the system was the physician and the hospital. Now we're saying that's not the way to look at it anymore, that we need to have the patient as the center and everything else supports the patient's health. As the patient's health changes from birth to death, that patient will go through different things in their lifestyle cycle, that they need to have different people coming in and out of the approach to help the patient. And I think this is something we need to talk about as we talk about primary care, about a patient-centered approach to care, about removing the emphasis on physician and doctor care only, and looking at how, as we said earlier on, housing advocates, social workers, teachers, school teachers, city councilors, how they, not city councilors, school teachers and school councilors, how they get into identifying that kid at risk from the early days, and how we can help that kid to go through all of the problems that they're seeing, picking up early signs, making sure that we help that person through their lifestyle to live the best possible quality of life that they can live. And I think that is another story and another discussion for another day on another panel, but we cannot walk away from it, because when everyone talks about overdose deaths, everyone only talks about overdose deaths. And they don't talk about what Kate was talking about. And they're not talking about what Scott is talking about and Perry is talking about, the work being done at Simon Fraser University on some of the things like housing and helping to find out about the trauma that people face. For me, I know that when we ran the Liberal Party, that we promised that we would put in our 2019 platform, we promised that mental health was going to be part of our Medicare system, because mental health, as you well know, has been left out. It's been like a sidebar. And Medicare was only for people who had physical ailments. And only when you got into a crisis phase did you get into the system with mental health. How do we get mental health to be seen in the same way as physical health is? preventing problems, getting them early, dealing with them and supporting them throughout life as a chronic problem that needs to be followed through, etc., especially at the peak points, you know, in life. I think those are some of the things that is really worth discussing about it. We promised we'd do it. And I think that I know that this is a promise we're going to keep, because we see how we can't have, you know, bits and pieces of mental health programs around the country that are not really cohesive and comprehensive and looking at national standards and national objectives and national indicators and national measurable goals. So I think we need to talk about all that. But I just wanted to thank you all for coming on, because I think, you know, as far as I'm concerned, the three of you have shed light on a question that has been getting high headlines, and that everyone has been weighing in on it, and it's always with a single answer to the problem and one single way of dealing with the issue. And we're never going to resolve this until we look at the complexity, until we look at all of the, again, the medical word, comorbidities of all the other illnesses, and at about the, as you mentioned, Perry, at the beginning, all of the people who during the course of their lifetime, from early childhood, suffered traumas in their life that actually created a situation in which they had to go to drug. I mean, we just have to look at indigenous communities to see all that trauma that occurred, that intergenerational trauma that occurred, that has created a system in which we see many indigenous people, when they were put into residential schools, taken away from their homes, and having to find solace in using substances to ease the pain and the trauma that has been going on for so long. And those are kind of issues that we need to now start talking about. And I think I want to thank you, because this is just not about the one thing. This is about how we actually talk about how we build a new system. The one that we had was great. It isn't working anymore. How long has the system been in since after the Second World War? We're talking about a 50-year-old system of social infrastructure, health infrastructure, et cetera, that really needs to move forward and shift and change and meet the changing needs of and the more that we know about certain problems that we didn't know about 50 years ago and how to deal with them. And so thank you for coming on. Thank you for your insights. Good luck, Perry, in anything I can do. We should chat about how we can get this nonprofit pharmaceutical moving forward so that we can provide the substances and the intravenous drugs that Scott was talking about. And Kate, thank you for bringing in this topic of which I really had hoped that you would bring in, and I know you would, because Julio has always been beating me over the head with this idea about comorbidities and looking at this as one big problem and not just one small problem and one linear problem. And thanks you for bringing this in, because I think it's time we started talking about how we deal with a lot of these issues very differently, not just about people dying, but about people living with a chronic disease state or a chronic problem, and how do we make their lives better. Perry, I'm glad you brought in the issue of treatment and rehabilitation. It's an old word, but how do we get people to get back into the world, to function as best as they can, you know, maybe get a job, maybe, you know, get a home, maybe get married, maybe have kids, maybe live normal functioning lives, even though they do have this chronic illness called a substance use disorder. How do we deal with all of those problems? How do we look forward to the future and build a very different future for everyone, and not have some people become so vulnerable that we throw them away and that we ignore the realities of their lives, and not just the realities of their death. So thanks, guys, once again, and I hope we can talk again. Perry, I want to hear from you about how I can help with getting you this nonprofit. Scott, you and I have talked about this before, and we know you've suggested some things, and I'm hoping that, you know, the federal government can at least do a temporary thing to help us to get an affordable use of some of the injectables that we currently have in the system now. And Kate, I want maybe at some time to have you on a different panel where we talk a little bit more about all of the things that impact on health and you know, and not just disease, you know, and on quality of life down the road. Thank you, guys. Appreciate it.
The opportunity.
Bye. Bye-bye.
Thank you.
Pleasure to speak with you all.